like to turn back to a patient who is on the bubble, potentially a candidate for surgery. But when you look at the films, you're at a multidisciplinary clinic, and the surgeon feels it's potentially going to need a pneumonectomy. How much or how little does that matter? Do you have a mindset that if you're talking about needing a pneumonectomy, and for the public audience, that means having a surgery to remove an entire lung rather than a lobe, 1/3 or half of a lung, depending on which side. So a bigger surgery, and some would argue that it's a disease unto itself to have a full lung removed. It's certainly challenging. Does that lead you to think if you're thinking a pneumonectomy, you should probably not be thinking about surgery? Or does this lead you to maybe think of giving pre-operative therapy to shrink it down? Is that a goal for you very often? Riyaz, maybe I can start with you on this one.
Yeah, I think so. This is a really important question, and it's a question that there isn't a lot of trial evidence to guide us. And in my experience, working through several MDTs, different surgeons have different thresholds for surgery. Different radiation oncologists have different thresholds for what is encompassable, what is not. This is a very, very gray area. Right. And decisions that are made are very individualized. And it's not that easy just to just make some sort of blanket statement about how they're managed, because it is very individualized. But as a general rule, if our surgeons feel, I think the patient has the best chance of cure for early lung cancer is surgery, basically. And if the surgeons feel they can offer surgery, they always will. And if they feel that there's a particular bit of anatomy that is pushing the patient to a pneumonectomy, a particular subset of the disease, its location close to the carina. They can do resections very close to the carina now with these sleeve resections, sleeve lobectomies, etc., etc. Then I'm not averse to giving some neoadjuvant chemo if they feel they would want me to do that. Even though that, I have to say, that is not a standard of care in the UK. It's highly controversial and causes huge debate. We can have quite robust arguments at our MDT between us about the management of individual cases like this. They're very complicated.
Right. I think it's a really good point just to underscore. There is no universal definition of unresectable disease. That is certainly a product of where you are, how aggressive your surgeon is, and somewhat the desires of a patient, and whether patients can be converted from not necessarily resectable to maybe moving into that camp. Estella, what's your
yeah, so
it really varies by location.
It does, and we have very heated discussions in Miami about this, and
which is at least a consensus. Everyone argues about these.
But we participated in Checkmate A16, which is a trial that randomized patients to chemotherapy nivolumab versus chemotherapy alone before surgery. And we enrolled patients predominantly who are stage 3. And from that experience and the activity that we saw in that trial and that has been published in terms of disease-free survival, at least of pathologic response, not disease-free survival, pathologic response, we are favoring some of these kind of gray areas for an induction that includes immunotherapy. And in that trial, they excluded patients who had EGFR and ALK. So it would just be patients that present. In that study, what they have presented is a small study, like 336 patients or so, but there were less pneumonectomies in the chemo IO arm. But one thing that really confuses me sometimes when I speak with surgeons is that there's a camp of surgery, thoracic oncologists who say that if you needed a pneumonectomy before induction, you still need a pneumonectomy after induction. And there's another camp who's more flexible, that you truly were downstage. And in this trial, they did restage patients in the mediastinum before surgery. So they're willing to do a less aggressive surgery, the patient truly downstage. So I think we don't really know that. I think that trial was very thought-provoking, and there is some activity, and there was some downstaging that was there. I think that was clear, yeah. But we don't know still if it applies to every patient.
Well, I think it was a controversial study. I think that trial you mentioned, Checkmate 816 of chemo versus chemoimmunotherapy before surgery, 2/3 of those patients had stage 3A disease, and a bunch of the patients in that trial needed a pneumonectomy. I mean, some of my colleagues feel that you shouldn't be probably pursuing surgery if you think there's a solid chance of needing a pneumonectomy. You also brought up the great point that there is this argument or question about if should you do the surgery that the patient initially needed or what the repeat imaging suggests. And one of my former surgery colleagues basically suggested it's like, as a tumor shrinks, is it like a puddle drying up where there may be pockets still of wet out there and it's not a clean border, or is it like a balloon shrinking where the new borders are really the issue and you don't need to worry about what's beyond that border? Narjust, what's your both perspective and sense of practice patterns and in terms of aggressiveness in favor of surgery on the bubble?
Well, I guess I'm going to answer depends again, but I think, having a good conversation with the surgeon has been always important, and having the multidisciplinary clinic, it is always good. I was raised by two surgeons, so if you ask the surgeon to take it out and they can take it out, they will take it out, right? So I think it's good to like hold in sometimes a little bit. Hey, let's just talk this a little bit better, to make sure the patient has better outcome. I think before even Checkmate 816, I had some special cases in which I would do neoadjuvant therapy, but they're more rare than the section, I think. And this is, understanding that my patient population a lot of my patients are very fit young women, so they're able to take the chemotherapy and then go to surgery, but that's not the case to every patient. So I think multidisciplinary discussions are important. I have done it before Checkmate 186, but it's not like the standard of practice for me.
Okay.
Although, Jack, I know that you don't like that trial, but 1 out of 4 people, one out of 4 people in that trial had a complete pathologic response.
I don't want to say I do like that trial. Actually,
okay, you do like it.
I do. I just think actually Dr. Ford, who presented it, kind of brought up that it has been criticized for the pneumonectomy rate. I think the results are very provocative, and we'll turn to that in a moment. I think it's interesting. One aphorism that Narjust comment reminded me of is never ask a barber if you need a haircut.